Hello. In this training segment, I and my colleagues Phil Kirk and Bill Hill will present the effects of clinicopathological characteristics of the tumor on surgical technique. Phil, would you mind starting by saying a few words about this section?
Well, we'd like to show you some of the key clinical and pathological features that are important in rectal cancer surgery. We've tried to find the important papers in the literature to illustrate these issues. However, the literature's poor and much work remains still to be done. But we've tried our best to make this as interesting as possible and to explain the key features. Ayan, would you like to start?
Thanks, Phil, of course. The aims of surgery in rectal cancer should be preventing local recurrence, in other words, local control, providing a longer survival, preserving both the urogenital intestinal functions following the surgery. For this reason, cases of rectal cancer must be individually assessed. The surgeon has to tailor the treatment for a patient while taking all the alternatives into account. For example, local excision versus radical procedures, sphincter-preserving modalities versus permanent colostomies, total mesorectal excision versus partial mesorectal excisions, and neoadjuvant radiotherapy or chemoradiotherapy versus adjuvant treatment. Miles described abdominoperineal excision for rectal and distal sigmoid cancers early last century. Since then, the biological characteristics of this cancer are more clearly understood. The physiological relationship between the rectum and the sphincters has been determined, and modern surgical techniques have developed. The behavior of rectal cancers varies according to their location. For practical reasons, rectum is considered to have three portions. The first 6 centimeters from the anal verge is called the lower rectum. The portion between 7 and 12 centimeters is the middle rectum, and above 12 centimeters is the upper rectum. The cancers of the upper third differ significantly from those of middle and lower third. As shown in the slide, 5-year local recurrence rates, local spread, and distant metastasis and cancer-related mortality are very different in the tumors of the upper third when compared to the lower rectum. Cancers of the upper third are similar to sigmoid tumors. For these reasons, surgical treatment of upper third rectal cancers will not be covered further here. Phil, will you now talk about depth of invasion and the importance of lymph node metastasis?
There is no doubt that the most important prognostic indicator for rectal cancers is the stage of the disease. Especially the involvement of lymph nodes has a crucial effect on the oncological outcome. 10% of all the submucosal, namely PT1 tumours, spread to lymphatics. PT1 cancers invading into the superficial third of the submucosa have only a 2% risk of regional lymph node involvement. However, this rises to 8% in the middle third and 23% in the deepest third. This increases to around 30% for the tumours invading the muscularis propria. Lymphatic spread can be encountered in up to 50% of those tumours invading out into the perirectal tissues. Furthermore, the size of the involved lymph nodes is also important. 40 to 50% of all the metastatic nodes are shown to be smaller than 5 millimeters. This fact may result in understaging during preoperative radiological evaluations. Therefore, one must bear this in mind, especially when considering local excision for rectal cancer. Depth of tumour invasion into and through the rectal wall, tumour differentiation, lymphatic invasion, and the location of the tumour also influence the number and pattern of lymph node metastases. Vascular invasion is also very important. Major lymphatic spread of rectal cancers is via the inferior mesenteric vessels. Lateral lymph nodes may also be involved. This latter condition is related to the location of the tumour. The more distally the tumour is located, the more frequently spread occurs to pelvic sidewall nodes. Ihan will now talk about the influence of the no-touch isolation technique on prognosis.
Securing lymphatic, vascular and luminal isolation of the involved segment of the bowel before any manipulation is known as the no-touch technique. When first described by Turnbull in 1967, this technique was shown to significantly improve the 5-year survival rates of colon cancers. However, later studies, including a prospective randomized controlled trial, failed to confirm a significant change in survival rates. All of these studies were, however, underpowered to exclude small but significant improvements in survival. Although liver metastases were shown to have developed later and less frequently with this technique, no survival advantage can be documented. The effect of high ligation of the inferior mesenteric artery on prognosis has been truly discussed in many series. When a lymphovascular pedicle is undertaken by performing a high ligation, all the lymph nodes following the inferior mesenteric artery can be included in the resected specimen. If the inferior mesenteric artery is ligated at the level just below the left colic branch, 5 to 10 lymph nodes remain around the root of this vessel. The literature shows no significant difference between high and low ligation of the inferior mesenteric artery in 5 and 10-year survival rates for every stage of cancer. A small prospective study on left colon cancer by French Association of Surgery compared the effects of high and low ligation on 5-year survival rates, and no significant difference was observed between the two groups. This result shows that the choice between high or low ligation has not been definitely shown to have a prognostic effect in left colon cancer surgery. To date, this question has still not been effectively addressed, and there is increasing substantial evidence occurring from Erlangen and Japan that it may be very important. Whatever the current evidence, high ligation is essential for a tension-free low colorectal and coloanal anastomosis. Now, I would like to turn Phil to tell us about the importance of distal margin.
The distal resection margin is also very important in the surgery of rectal cancer. The related literature revealed that in most tumours, distal intramural spread will be no more than 1 centimetre, allowing increased numbers of low anastomoses to be created in low rectal cancer. Sir Ernest Miles had stated that in all the tumours below the peritoneal reflection, distal intramural spread can only be managed by abdominoperineal excision. But since then, the concept has changed significantly. John Gallagher was the first to claim a 5 centimetre distal margin to be necessary, and later Paul Hermannek reduced this to 3 centimetres. A study from St Mark's Hospital revealed that local recurrence, 5-year survival and cancer-related death rates did not differ significantly when resections with distal margins less than 2 centimetres were compared to cases with margins greater than 2 centimetres. Another study showed that even a 1 centimetre tumour-free distal intramural margin is sufficient. However, intramural spread, which is the tumour spread within the rectal wall, is different from the tumour spread within the mesorectum. The tumour spread within the mesorectum is much more important for obtaining complete excision. I will now pass to Bill to tell us about the mesorectum and local recurrence.
This diagram has been copied thousands of times, and that paper, I am told, is the most frequently quoted in the whole colorectal cancer literature. It is a concept diagram, and it points up an important practical priority for the surgeon, which is that he can afford to have very little clearance along the muscle tube, but that he must have the traditional 5 centimeters of clearance of mesentery distal to the lower margin of the cancer. Either that, or he must take, in the tumours below about 10-12 centimetres, he must do a TME. He must take the total mesorectum and leave behind just a little muscle tube between dentate line and perhaps a maximum of about 5 or 6 centimetres. He must not leave mesentery in the bottom of the pelvis if that mesentery was anywhere near 5 centimetres below the edge of the cancer. In practical terms, that means most cancers at or below 12 centimetres will require a TME, and those higher cancers, and particularly those that mobilize up nicely, can have a partial mesorectal excision with mesorectal transection. In essence, what we are saying is that mesorectal fat anywhere near a rectal cancer is dangerous. The muscle tube is safe enough, probably a centimetre away from it. But look at the mesorectal fat, and at least 70% of rectal cancer cases will have satellites. And if you look at the work of Professor Gu in Beijing, he will tell you that the harder you look, the more tiny deposits you will find. So let us regard the mesorectal fat as dangerous tissue to leave in a patient. Fortunately, we have a lovely areolar plane outside this embryological envelope of tissue, created because the gut is a midline structure with a midline blood supply coming from the front of the aorta, and around each of the colorectal cancer operations, we can define an envelope which will safely encompass the principal primary lymphovascular field of spread of the cancer. That paper with that diagram, that concept diagram, included the first of these data, a deposit 4 centimetres beyond the lower edge of the cancer, and others also shown, reported at different times, various randomly distributed deposits within the mesorectal fat beyond the cancer. This rather contradicted traditional data that came from Gallagher and some of the St. Mark's workers, which suggested that all the drainage was upwards. When I went to Beijing to operate at the Beijing Cancer Hospital, I was delighted to see that Professor Gu there was making a major enterprise of, first of all, naked eye quality of the specimens, back and front and lateral, in parallel with what's going on in Europe. And then he was looking in Beijing at smaller and smaller lymph nodes and finding them in just the places in the mesorectum that the surgeon is likely to miss if he does not stick religiously to the holy plane around the embryologically determined midline TME envelope of tissue, so that he showed how dangerous the mesorectal fat indeed is. TME, or a partial mesorectal excision with at least 5 centimeters of clear, complete mesorectum beyond the edge, seem to be the keys, the principal keys to curing rectal cancer reliably. These facts are further and more recently confirmed by the patients who have failed. Our colleague and friend at the Karolinska in the radiology department there, Lennart Blomqvist, reported that more than half of the local recurrences within Sweden referred to him for MRI analysis in fact showed not only the local recurrence, but a residue of mesorectum leading to that local recurrence. In other words, he was able to say that incomplete mesorectal excision is the principal cause of failure. And he actually reported only a tiny percentage as being due to extra mesorectal lateral wall lymph nodes, probably no more than 2-4%, a small percentage of local recurrences due to that particular failure. So TME is vital in the cure of rectal cancer, but sadly a challenging and difficult operation to perform, requiring specialist training and every form of visual or video and detail technical encouragement and training. So, Phil, over to you to tell us a little about the histopathological basis of the primacy of circumferential margin involvement.
Another important reason for local recurrence after rectal cancer surgery is the involved circumferential resection margins. The circumferential resection margin is the distance between the tumour cells and the fascia propria recti or mesorectal fascia. The distance between the surgical margin that should lay on the fascia propria recti and the closest satellite is to be taken as the lateral surgical margin or circumferential resection margin and be measured in millimetres. Slicing the specimen into thin slices, as shown here, allows us to see the extent and types of tumour invasion into the mesorectum. It also allows the identification of peritoneal involvement and circumferential margin involvement. The measurement of the distance of tumour to mesorectal fascia is important, as the closer it is, the more frequently we see local recurrences. In the past, we showed that the local recurrence rate for positive lateral surgical margins was 85%, whereas it was just 3% for negative lateral margins. Since then, the circumferential resection margin involvement rate has been regarded as the most important indicator of local recurrence after rectal cancer surgery. Here, the relation between local recurrence and circumferential margin is shown as found in the Norwegian Rectal Cancer Project. As the microscopic distance between the tumour and the circumferential margin increases, local recurrences decrease. Likewise, when the Norwegian cancer database is reviewed, a correlation between circumferential margins and survival rates is clearly observed. Thus, millimetres of clearance do matter. The surgeon has to be very careful when attempting to avoid an abdominoperineal excision by undertaking an intersphincteric excision due to the potential for coning leading to involvement of the circumferential margin by tumour. Ihan, will you please continue by discussing locally advanced tumours?
In the case of locally advanced rectal cancer with invasion of the adjacent organs, the surgery has to extend to resect the involved organs en bloc with the rectum. This is essential to achieve tumor-free margins. Limited excision of the infiltrated areas rather than a complete resection of the infiltrated organ often leads to a positive margin and increase the risk of local recurrence. The significance of radical resection is clearly shown in this study. En bloc resection of the involved organs has resulted in significantly reduced local recurrence rate and increased 5-year survival. When the surgical margins are positive, local recurrence rates increase to 77% and 5-year survival decreased to 23%. Another issue that deserves special attention throughout the rectal dissection is the perforation of the tumor or the rectum itself. Pelvic contamination and tumor implantation will result in increased local recurrence and reduced survival rates. In another series, local recurrence rates increase up to 40% and 5-year survival rates decrease down to 44% with intraoperative perforation. Norwegian cancer data have clearly indicated that perforation had a very high local recurrence rate and a very poor survival as compared to no perforation group. A substantial difference in the outcome if the patient has perforation. Lateral lymph node involvement is also important in rectal cancers. Lateral lymph node dissection is routinely performed in Japan, but this is not the case in Western world. The involvement of the lateral lymph nodes very much depends on the location of the tumor within the rectum, with the lowest tumors having the highest rates of lymph node involvement. However, the only randomized study investigating the efficacy of lateral lymph node dissection showed no significant effect on 5-year survival and local recurrence rates. However, this was a very small study and more work is needed to resolve this issue once and for all. The rationale for not performing a lateral lymph node dissection on a routine basis in Western society is that these patients may also have systemic metastasis or receive radiotherapy or radiochemotherapy for locally advanced diseases. Therefore, the number of patients in this stage who would benefit from this kind of an intervention would be small. Additionally, the morbidity and mortality are significantly higher following lateral lymph node dissection. Anastomotic leakage after a low anterior resection for rectal cancer can lead to an increased risk of local recurrence and reduce the life expectancy. Here, a distally located end-to-end coloanal anastomosis is being shown. Coloanal or distal colorectal anastomotic leakage rate is around 10% in the literature. Anastomotic leakage affects both the local recurrence and survival rates negatively, as shown in the slide. Now I will ask Bill to comment on the importance of surgical training in rectal cancer surgery.
I suppose there is no one who has spent more of his life involved in training surgeons to do TME operations than me. Perhaps that's inevitable since it was I who described it in the first place, and I've been doing it and videoing it ever since and trying to refine it and improve it ever since. Perhaps the most spectacular first effects of all these efforts at workshops, practical video-based workshops, was from Sweden. Gunnar Abman from central Sweden did a thesis and showed a substantial impact in halving from 14 to 6.5% the local recurrence rate from workshops in central Sweden. Enker, of course, in the United States was working in a parallel way and was reporting his own results, which showed an even greater fall when he adopted the TME technique. Similarly with Volpe in the United States, incidentally an old personal friend of mine. The Stockholm radiotherapy trials are well known as Stockholm 1, Stockholm 2. And I was rather hoping that our surgical technique training program would get called Stockholm 3, but they preferred to call it the TME project, and that's exactly what it was, an attempt to train all the surgeons in Greater Stockholm between 1994 and 1997 with a very large number of workshops. I mean, I've now been more than 80 times to operate in Sweden, and almost always with video relay to groups of surgeons. So this was a unique initiative, and the results, when they were published from follow-up, showed a far greater impact of surgical workshops to train people to do TME surgery than all of the adjuvant therapies added together could possibly claim. A huge difference, a fall in local recurrence rate, which you can see on the slides, a fall in cancer-related mortality, and also a dramatic fall in the number of permanent stomas in this entire population of Stockholm. So we believe that that was the first time that the value of practical surgical training could be shown to impact on cancer outcomes in a whole defined population. Rather similar results were achieved in Norway, as you can see here from Arne Weber's data from the Norwegian Cancer Registry. Again, a dramatic fall in local recurrence and a dramatic increase in 5-year survival. I don't altogether understand why the anastomotic leakage fell so dramatically, but presumably that, as a technique-related complication, that also was improved because the triple stapling technique had been widely disseminated throughout Norway, along with 48-hour presacral space drainage and the very frequent use of temporary proximal stomas. One difference with the Norwegian data, which is important, is that there was very much less contamination of the results, if you like, by the use of radiotherapy. Much more radiotherapy in Sweden than in Norway, though not in such a way as to bend the TME impact. The prognostic factors for local recurrence appeared primarily to be height, stage of tumour, but most of all, operative technique. This is analysing data from across Norway, and it suggests again that the surgeon's detail is the most important predictor of outcome. You see here, this is a subgroup analysis from the Dutch TME study and the naked eye analysis of the completeness of the mesorectal excision. And there again, dramatic difference between a visibly incomplete mesorectum and a complete mesorectum, a perfect TME result as judged simply by looking at the specimen. And it's encouraging to know that the Germans have introduced visual analysis as an important part of data collection in Germany. The specialty of the surgeon, in other words, whether he is fully trained as a colorectal surgeon and has specialized in colorectal disease, or whether he's a general surgeon with a perhaps unspecified minor interest in the colorectal side, that also makes a measurable difference. And no doubt that simply reflects the greater likelihood of the specialist to do a better TME. The Association of Coloproctology of Great Britain and Ireland produced similar data. And in Spain also, a better result in terms of local recurrence when specialization enters the equation. The other obvious factor to look into is the actual number of cases that are done each year by a surgeon. Though I would counsel some care about this, because the original observations from Germany, from Hermanegg, actually had the worst results of all coming from one particular German surgeon who was doing a very large number of cases. So I would view this data with just the realization that what I feel sure, are talking about is the care with which the operation is done. But of course there is a minimum number that are necessary for that care to be effective in terms of better TMEs. 10,000 patients in McCall's meta-analysis again showed that surgeons trying to do TMEs were in fact getting much better results than surgeons who did not even claim to be tackling the TME challenge. The local recurrence rate in Koechling's study from Germany, it relates to the impact of local recurrence on 5-year survival, and of course that is dramatic. Only 23% of those who do get a local recurrence actually survive 5 years, but that's unsurprising. Down the left-hand side of this slide is a number of prognostic factors over which the surgeon does not have direct control, though he can be forewarned of some of them, and that is another side of our instructional planning. But most of those are factors which are put there by the tumour itself, and it is in reality the surgeon-related factors which can be influenced by training. And these will, of course, include rupture of the tumour during the dissection. They will include planning by selection for preoperative chemoradiotherapy in high-risk cases. And these will be discussed along with MRI and other aspects of the planning. What is unfortunately true is that if we do fail, there is no form of neoadjuvant or adjuvant therapy that has ever been shown to correct that failure. One of the truest statements that has ever been made about rectal cancer surgery is that what is omitted in the first operation is lost forever. To summarize, There is probably no malignancy where the outcome from surgery varies so much between one unit and another and between one surgeon and another. This bears witness to the fact that the precision with which the TME is undertaken and the devotion that the surgeon invests in following the holy plane around the embryological, oncological envelope of tissue, that is what will determine the patient's chances of cure. There is no cancer operation where results vary so much and where so much can be achieved by better training and better precision surgery.